Hello everybody, this video will present deep anterior lamellar keratoplasty in post-microbial corneal scar. This case has a deep corneal scar reaching to near descemet membrane and probably affecting the predesmetic layer. So after the usual central marking and adding some peripheral marks to include all the thinned areas in the trephination, and after partial trephination is done, air is injected into the peripheral stroma to whiten the stroma and not aiming to a formation of the big bubble. But when injecting air near the corneal scar, a type 2 bubble has formed. Now superficial keratectomy is done. This is followed by a paracentesis and injecting some air bubbles in the anterior chamber. This is to decrease the pressure in the anterior chamber and to act as a confirmatory signs for the presence of the bubble. Another layer of the stroma is removed, leaving the central part attached to avoid sharp dissection in the thinned central area. Now our aim is to reach as near as possible to the predesmetic layer. So we use the small microbubbles as a guide for dissection, opening on one of the microbubbles using a bent insulin needle, followed by blunt dissection using a spatula. This is followed by cutting off the dissected stroma using scissors. It is to be noted that we are performing dissection in the peripheral cornea to avoid the scarred, thinned central part. During cutting the stroma, dissection of some areas may be needed using spatula before using the scissors. After completing peripheral dissection, now I'm going to try to peel the central area. During peeling, I realized the scar is adherent to the predesmetic layer and there is a risk of type 2 bubble collapsing. So I opened the roof of the bubble under viscoelastic and injected some viscoelastic to keep the plant between the scar and the predesmetic layer. Peeling is then completed, removing all the remaining stroma. Now we come to the last and most important step in the surgery, which is bearing of descemet membrane. It's obvious that the scar is involving the predesmetic layer, and to achieve optimal visual outcome we have to bear descemet membrane. Complete bearing of descemet membrane carries a very high risk of rupture and conversion to penetrating keratoplasty. So our aim is to bear the central 3 to 4 mm only, cutting the scarred predesmetic layer by small snips of a blunt corneal scissors, forming a central window in the predesmetic layer. This step should be done carefully, avoiding any increase in the intracameral pressure. The predesmetic layer should be held using a fine-toothed forceps away from descemet membrane to avoid any possible pressure on the fragile descemet membrane. So irrigation of the bed and the graft is then done. It's to be noted that the stream of BSS should be directed away from the central bare descemet membrane. This is followed by fixing a descemet membrane of graft using 16 interrupted 10-0 nylon sutures. More data on this technique will be found in this publication. Thank you for watching the video.